Hi guys, my name's Ollie. I'm a final year medical student at Warwick. Dr. Gills asked me to put together a few finals cases that will be really good for us to work through together. And this first one is going to be about depression, obviously under the banner of psychiatry. Obviously, I know nothing more about depression or medicine or psychiatry than any other finals level medical student. This is simply going to try and be a summary of the relevant things that I've learned while speaking to psychiatric patients and condensing a lot of the clinical tips and pearls that I've been given by registrars and consultants on psych placements. So let's say we have a 42-year-old man who comes to his GP and says, I just don't feel right, doc. I feel really tired all the time. I'm struggling to get out of bed in the morning, but I've been waking up really, really early and can't go back to sleep. And then once I'm up, I just can't motivate myself to do anything in the day. I'm not eating well. I've lost a bit of weight. This has been going on for about 4 months. And if we were to dig as to whether anything happened about 4 months ago, he was made redundant from his job. He used to work as a railway engineer. He was made redundant, and since then, things have kind of been getting steadily worse. So as I'm sure is very obvious to most of you by now, this is quite a common presentation and precipitating situation for depression. And speaking purely for myself, my experience in psychiatry was that the histories are much more about talking and exploring the presentation rather than just focusing on the signs and symptoms. It's really getting a good holistic picture of what's been going on with them and how they're doing. But obviously we've got exams to think about. We're under time pressure in our OSCEs, our long cases. So with depression, I usually like to split it down into a triad of core symptoms and the key cognitive symptoms, because these are the key things that are going to help us establish our diagnosis. So the first core symptom is low mood, which obviously is the element that most people think about when you say depression. So how has your mood been recently? Does it fluctuate? Is it worse at any particular time of the day? Does any situation make it better or worse? We're just applying the standard kind of Socrates investigation that we would use for pain to try and learn more and localize their symptoms. And while we're asking about mood, I actually like to flip this the other way here and ask if they have periods of feeling excessively happy or super energetic, because this is an opportunity to screen for mania. So this might actually not be an isolated depression, it might be a presentation of bipolar disorder. Then the second element is anhedonia, or loss of pleasure in things that you would normally find pleasurable. So going into things like, how do you fill your day? What are your hobbies? What did you used to like to do before things got bad? How much do you do them now? And then lastly, anergia is the third core symptom. What are your energy levels like? How is your sleep? Do you have any problems getting to sleep? If you wake from sleep, do you find it difficult to go back to sleep once you're awake? They might have decreased concentration, so that's things like, do you find yourself easily distracted when you're doing things? How about watching TV or reading a book, for example? Memory problems, so just have you noticed any problems with your memory? Has anyone else noticed anything or said anything to you? Then feelings of either lack of self-worth or excessive self-blaming is the third feature. And then number 4 is nihilism. Like, there's no real point to anything, I'm not motivated to do anything, everything is futile. Those are the 4 cognitive symptoms that we need to screen for. So that's 7 things to look out for, and we also need to know how long each of them has been going on for. We'll talk about a diagnosis later, but basically for something to qualify as a depressive episode, the symptoms need to have lasted for at least 2 weeks. Whatever they are. So now that we've explored the bulk of the history of presenting complaint for those 7 features, the really important thing to assess in a psych history is suicide risk, or risk of self-harm, as well as potential risk to others, because remember, it's not just the patient, it's the people around them. And I think there are many ways you can approach this. I've seen consultants sometimes use a warning shot, some of them seem to prefer not to and just jump straight in, but this is what I would do. You can start by asking, do you ever feel that life is no longer worth living? Have you ever thought about taking your own life? If they say they have you ever made plans? Have you ever tried to take your own life? And then obviously, have you ever thought about hurting anybody else? Because that can obviously change the clinical scenario, and we might need to consider admitting them. And once we've ascertained that risk of self-harm, we also need to screen for schizophrenia. In this situation, there are a few quick questions we could use to do that. You know, do you ever see or hear things that other people say they can't hear? Do you ever feel that anyone is out to get you? Do you feel that anyone else can read your thoughts or put thoughts into your head? You've heard all of these before, but the standard screening questions. Moving on to the past medical history, we can always ask about hypothyroidism as quite a common organic cause for depression, or indeed a chronic illness of any description, because that is a major risk factor for developing or presenting with depression. The patient may of course already have a known mental health problem, they may already have a diagnosis of depression or have presented with a depressive episode before. And in my histories I tend to group family history of any mental health problems here in first degree relatives, so that's parents or siblings, because just as in physical health, there is a genetic predisposition for developing depression. And once again, the normal questions about allergies, over-the-counter medications, herbal remedies that they might take, all of that will be important. Then moving on to the social history, we can look for two really important things. The first is evidence of a trigger of some sort, because presentations of depression, at least according to the literature I've read, tend to be a combination of a predisposition or a predispositional state plus a trigger to cause the episode. So in this case, we know that this man was made redundant from work, but other common triggers for depressive episodes include breakdown in personal relationships, either being made redundant or retiring because people lose their routine and kind of sense of self-identity, as well as more obvious things like the death of a relative or someone significant to you. The other element is we need to explore their home situation as well. Who lives with them? Do they have a partner? Do they have children? Where are you living? You know, are you living in a house, in a bedsit, in a hotel? We need to know about their personal support network, friends, family, work colleagues, and so on. And on that note, whether their mental state has interfered with their work or required them to take time away from work so far. And then it can be useful to ask if their mood in general has affected their relationships with anyone else, because these things can form a bit of a spiral. Then lastly, in the social history, we do need to record details of smoking, recreational drug use, and alcohol consumption. Because again, particularly the latter two, these can influence the presentation of certain psychiatric conditions. Investigations, according to the clinical guidelines, are pretty sparse, thankfully. It might be a good idea to do full blood count to rule out an anemia, which might be the cause of the fatigue. We can do thyroid function tests to quite easily check for a hypothyroid picture. And then you may want to consider using a 𝐎𝐥𝐢𝐯𝐞𝐫 questionnaire, which asks them about the symptoms of depression, which can be used for monitoring and follow-up further down the line and used as a sort of prognostic marker potentially. And then lastly, we can move on to the diagnosis and management, which is thankfully quite simple. In keeping it very surface level, depression is usually grouped into one of three levels: mild, moderate, or severe. To hallmark a mild case of depression, we're looking for 2 of those core symptoms plus 2 of the cognitive symptoms. And for mild cases, we're just thinking about low-level interventions. Usually this is going to mean something like CBT, a low-level psychological intervention, and you can consider starting them on an antidepressant as well as some basic lifestyle advice. Obviously, if they are smoking or drinking a lot, trying to cut those things down, trying to look after their sleep as much as possible and stay in a routine. But then thinking about a moderate case of depression, that's again 2 of your core symptoms plus 3 or 4 cognitive. Then for a moderate case of depression, we're talking about again 2 core symptoms plus 3 or 4 other symptoms from that cognitive and somatic list. Then for a diagnosis of severe depression, you need all 3, that triad of core symptoms plus at least 5 other symptoms. And the treatment pathway for moderate and severe depression seems to be somewhat the same. The gold standard of initial treatment is a combination of an antidepressant medication, so something like citalopram or fluoxetine 20 mg once daily, and psychological intervention, which is usually going to be CBT or perhaps group therapy. You may need to try another antidepressant or a different type of therapy if they don't respond very well. In very severe cases, you need to consider referring for ECT, electroconvulsive therapy. And what this involves is the patient is sedated under general anesthesia, and essentially a small seizure is induced. And they usually have this done 2 to 3 times a week for between 6 and 12 total treatments. It depends on the local clinical guidelines. Just some general rules with depression patients. All patients with known depression need ongoing review of how they're getting on and ongoing risk assessment, as well as a relapse prevention plan for if things start to turn again. If they have other symptoms, so they might be severely agitated or have psychotic symptoms, you can medicate those as well. If they're agitated, consider a benzodiazepine like lorazepam. If they have the psychotic symptoms, consider something like quetiapine. And again, as a general rule, psychoeducation as an ongoing process with the patient can be really helpful. So just as a quick summary of everything we've covered, depression is a complex and multifactorial mental condition which usually results from a mix of factors and is often summarized or explained as an imbalance within the brain of the chemicals that control our mood. The most prevalent theory is the monoamine hypothesis, which posits that underactivity of monoamines, particularly 5-HT, 5-hydroxytryptamine or serotonin, is usually the culprit, although again we don't fully understand. Then lastly, I thought it would be useful to cover 3 Viva questions, the type of thing you might hear at the end of a long case. For example, the first one, give 5 risk factors for depression: age over 65, already having a chronic health condition of some sort, family history and a first-degree relative of depression, use of the oral contraceptive pill, or being immediately postnatal are all quite major risk factors. Then what about 3 common side effects of antidepressant drugs? Just thinking about SSRIs, I'm sure you're all familiar. Weight gain, sexual adverse effects, and actually an increased suicide risk while taking an SSRI, as paradoxical as that sounds. And then lastly, what is serotonin syndrome? It's very, very rare, but it's a collection of symptoms that develops when you have too high a concentration of serotonin in your blood. Usually presents with hypertension, tachycardia, and sometimes with a fever. But that fever, when it does appear, can be very extreme, like above 40, 41 degrees. It's usually caused by taking 2 or more serotonergic drugs together, such as SSRIs, tricyclic antidepressants. The thing is it can present very, very quickly and it can be very, very dangerous. So looking at people's prescription charts and being careful not to give them multiple serotonergic drugs is really important. So thanks guys, I hope you found this teaching case useful. It was certainly good revision for me and I hope you found it somewhat tolerable. Thank you Dr. Gill for sorting out this series of videos and wishing everyone, including myself, the very best of luck for finals. Thanks guys.